Good
Can you hear
afternoon,
us?
Dr. Lee.
Oh, good afternoon.
Okay, you are on the
So
screen,
we have.
so yeah, please
Okay,
explain your team and your case.
Okay, actually, I'm not the first operator here. We have Dr. Bersin here, and
Hi, good
yeah.
afternoon. This patient is a 83-year-old female. Let you give the history.
Yeah. So this patient is an 83-year-old female. She received a history as a previous PCI 1 year ago. She came here because she recently complained of left leg claudication. She is a very active woman, albeit her old age, and we checked her ABI and it was 0.74. So the physician checked the CT angiography and showed a long segment total occlusion at the left SFA. So we are today dealing with this long segment CTO with Dr. Bersin here. And hopefully her renal function is okay, her heart function is okay, everything is okay.
So what we have is an 83-year-old with Rutherford 3 claudication on minimal exertion, ABI 0.74, long segment isolated total occlusion of the SFA. That's probably at least 20 centimeters, perhaps more. What we'll show you now is what we've done thus far. We access from the right femoral, went up and over. We have an 8 French flexor sheath in place in the left common femoral. And if you'll display the initial angiogram, I don't know if you can see this.
Maybe you can show them the CT first.
Yeah, you want to see CT would be fine.
Yeah.
Yeah.
So they can
Okay, there's the
understand
CT.
the situation. Yeah, this is CT. You can see that the stump of SFA is preserved, and the occluded segment is quite down below there. The one thing I think that very good thing is that we don't have lots of calcium in the CTO segment, and the distal reconstituted area is far from the popliteal. So I think that's very promising. Okay, so let's go to the angio.
So now if you can display the angiogram, can you see the initial guide sheath injection from the contralateral?
Yes, we can.
Yes.
Okay, so you see there's a subtotal occlusion followed by a little trickle flow and then multiple other occlusions. So it becomes a long segment total after that initial tight lesion. So our approach to this initially was to use a CXI support catheter and a V18 wire. If you'll go to the next,
Okay.
I'll show you what we have done thus far. Here's the V18 wire passing down by itself. It crossed that tight lesion very easily. Go to the next. We then gradually advanced the CXI catheter along with it and made some good progress. Go to the next. Okay, keep going. You can see it turns there and it sort of reaches another meniscus. Go to the next. And here we're passing down and it takes this turn upward, as you can see. And no matter what I did with the V18, it just kept curling up. So a trick is to just butt the CXI right into that occlusion and see if you can pass through it. Go to the next. We did an angiogram here to confirm we're okay, which we are. Go to the next. All right, so go ahead and play that. That's the CXI by itself, passed through the cap with no wire. Okay, go to the next, which worked very well. Now down in this area, we reached another occlusion segment, which was quite hard. No matter what we did with V18, it would just curl and bunch up. It was clearly a very hard spot. So at that point, we switched over to a high gram piercing wire, used an Asahi 20 gram. Go to the next. And that was able to traverse the occlusion with some effort. Honestly, it was quite hard at this point. The distal cap was quite resistant. but we were eventually able to pass the Asahi through.
Sorry.
Okay, next. And there we go. So we did some confirmatory imaging because it was a bit uncertain at that point whether we were in the true lumen. So go ahead. We did some angulated injections, and we were pretty comfortable that we were okay. You can see in this view, it appears to be in the lumen. Go to the next. All right, and go to the next. So in those two views, it looked good. Now the CXI wouldn't cross because of the hard nature of the distal cap, so we went ahead and ballooned that with a 2.5 millimeter balloon. Go ahead. And keep going. So with that, we were able to get across. So now we switched out the Asahi wire for just an extra support floppy tip wire. And let's do an angiogram. That's what we've done thus far. And let's take I'll just fluoro first. Ready to take an angiogram?
Okay.
Okay, so as you can see, we're through this occlusion. You can see some trickle flow going down now. So now the question is, what do you want to do? I think I'm in true lumen all the way.
Bob, you confirmed your wire is going through the true lumen?
I really think it is the whole way. If it's subintimal at some point, not much.
So Bob, it's Lawrence Garcia. At 20 centimeters, 25 centimeters, true lumen, I think you really have an option to do just about anything here. If you just want to reestablish flow, I would think that a balloon angioplasty result's not going to be the one that'll give her long-term durability. So the question is, are you still comfortable with DCBs given the current environment? Or are you more comfortable giving a scaffold that could be a non-stent DES or a stent DES approach for something like this? I mean, in our recent past, we would still go with DCBs as an alternative, but I don't know what the current environment is here in Korea.
Yes, right. It's all very good points. I can tell you from using the Estado wire here distally, it's a lot harder than you would think based on the CT. And the calcium content. This was quite hard. I honestly felt as though I was trapped in a cementable calcium space for the longest time, but I wasn't. And you can see there's a fair amount of calcium present. So I'm in favor of maybe doing atherectomy and a regular adjunctive balloon here. I'm informed here in Korea there's an interesting insurance rule that if you use atherectomy, you cannot apply a DES afterwards. You can only apply DCB or POBA.
Right.
So if we go the atherectomy route, we're a little bit trapped from an insurance standpoint to finish without a DES. So we could use bare metal for bailout if need be. We could just use POBA, and if it looks great, I think we walk away. But I'm feeling as though we need to debulk this.
Which device are you choosing?
Well, we're thinking here maybe Jetstream would be a good choice. Not too big. Would core out a lot of the thrombotic component. I think the top half is softer and very thrombotic. The distal half is calcified. Might be a good choice.
We have a distinguished discussant, so I think that we should discuss about the treatment strategy for this relatively long SFA CTO. Any comment or?
Fabrizio?
I mean, another option could be also to do a small pre-dilatation using like a 4 millimeter balloon and see how the vessel react. And then you can decide maybe to do a atherectomy just where there is a more severe calcification, and then you can move forward for DCB.
Well, that's actually a very good point. I was going to maybe go a little smaller with a 3. Do we have the 30200?
30200.
닭도 요거에
Like do a test inflation, if you will, and see how
닭도
it
요거에
responds.
Yoshi?
No
3 millimeter,
opinion.
200.
No opinion right now. Any option is okay, but DS the one of the options is very straightforward.
So we're loading a 3 millimeter 200 balloon. It's, I think, a good suggestion. We had thought of this beforehand to test the occlusion before we do anything else. See how it reacts. It doesn't preclude following up with atherectomy. It's too small to cause major dissection or other problems. But it gives us a feel for what we're up against. And the other question to discuss, perhaps while we're doing this, that's good there, to go on up, is embolic protection.
Okay. Let's go.
Whether to do that after the pre-dill here. I don't think the pre-dill will embolize much of anything. It's too
Okay.
small.
10. Okay.
That's a 3 millimeter by 200.
Right.
Store the image.
Start.
Now we'll just pan up and see how high this goes. It's almost long enough. It's probably just a little puff of contrast. Let's see how short it is.
Contrast, yeah.
Just a
Contrast,
little
yeah.
contrast. See if it's... it's long enough.
Yeah.
So a 200 length is perfect here. I'm going to demag one so we can see everything.
Okay.
I got it.
Okay. Right here.
Yeah, that's good. Okay, you can come down.
Okay. Deflation.
And let's take a picture. I think I'll make up just one here.
Right here. Oh, sorry.
That's good. All right, ready? Okay, go. Wow.
Wow.
That looks pretty darn good.
Yeah.
It does.
Well, panel, now what do we do?
The response is quite good.
I'm inclined, based on this favorable response, to keep dilating and see how well it responds without doing atherectomy. What do you think?
I think it sounds very reasonable. I mean, it looks lovely, and I think you did hit it in a true luminal fashion. There was just that one area that was distal, which is where you were up against the wall, but it seemed to dilate and give
Stop and
pretty nicely.
overlay the image.
Okay. Stop.
So back up.
Dr. Bersin?
Okay, good.
Dr.
Overlay that.
Bersin?
Yes, yes.
Do you usually the predilation with this small balloon in the usual cases? In my case, usually when I'm pretty sure about the position of wire in the true lumen, usually I use more bigger balloon for the predilation, but you use maybe 3.0 diameter balloon.
Yeah, this was what I call in the category of a test inflation, just to feel it out. It wasn't intended to be definitive by any stretch. But yes, if I'm very comfortable of where I am and the lesion characteristics in terms of calcium and hardness, I'll just go right up to a bigger pre-dill balloon. In this case, there were a lot of hard components, several places where I showed you where it was tough. I mean, I had to really push the Estado to get through. So I was uncertain. The last thing I wanted to do was put up a big balloon in a very tight spot and create a dissection, and then you're obligated. It reduces your options. So, but now given this response, let's have a 5 by 200. Yes, and we'll see how it responds to that.
Yep.
So if it's looking very good, leave it or DCB it?
Well, what do you think about it, Pounds?
Well, CTOs have a high recurrence risk. I think in that circumstance, like I commented yesterday, where you know the incidence of a recurrence is very high, then I think use of a low-dose DCB is reasonable.
Yeah, actually in Korea, the KFDA also warned the operators according to the FDA recommendation. So as an operator perspective, I'm quite uncomfortable of the warning, but still it didn't change my practice yet.
So let's see how it responds and while we think about that.
Okay, the balloon's going down. Here, a little bit more.
Right there.
Right there. Still,
A
there's
little
a
further.
proximal.
You can go just a little further.
further.
Right there.
Right here.
Yeah.
Okay.
Perfect length, actually.
Good.
Okay, up you go, gradual now.
Go. 천천히 갑시다.
And that's still a 200 millimeter balloon, is that right?
Right.
That's
You're right.
correct. Yep. It's a 5 by 200 Paseo. Gradually to 4. Okay, you can come off the overlay.
Okay. Yeah.
You can see how the balloon looks. All right. 5. We're going very gradual. Try to minimize dissection risk here. 6. Looks like a good size. 7. Yielded at about 7. That's not bad. Okay,
Are you
just
going
go-
to do
go
a
to 8.
prolonged? Sorry. Are you going to do a prolonged inflation with this balloon?
Great question. I was just thinking of that. So I think we have time for a 2 to 3 minute discussion here of how to finish this.
조금 앞.
Let's assume for this discussion that after this 3-minute inflation, it looks good. What would you recommend? Silence. Lawrence?
Yeah, I think I was waiting for somebody more intelligent than I to give an answer. I don't know. I was just going to kind of tongue-in-cheek say that, what's optimal angioplasty these days, right? I mean, we really don't have a good sense of it, but I think if it looks really good and there's limited dissection, I think you could probably. The challenge I have is I'm still internally trying to decide if it's going to be a PTA alone without DCB. Then in this world of 20 centimeters, I think you're obligated to stent. If you're not going to use a DCB, if you're going to go down the road of a DCB, then obviously we have the opportunity for focal restenosis or even diffuse restenosis, but it'll be a restenotic rather than a reocclusive. So I'm still trying to figure out what I would do here. I think that if I'm destined not to use a drug-coated balloon, I would probably go with a scaffold is my thought.
Wow.
What do you think?
Well-
You're working in the local environment. So.
Yeah, basically, I think not only for me, but most of the Korean operators prefer no stenting strategy in this long lesion.
No stent.
Yeah. Unless there is a major dissection or complication. So if we saw that the response of the balloon with 3 millimeters was quite good, and if it's just good enough for the 5, then maybe we will go on to a balloon or a DCB.
So my only comment would be the recurrence risk of a 20 centimeter CTO treated by PTA is extremely high.
Exactly.
So I think we should think about doing something, either a DCB or DES.
Yeah.
We have the option of either since
Sure.
we did not do atherectomy.
Right.
If it looks great, do we have a low-dose DCB here?
Sure. Lutonics.
Lutonics,
Yeah.
okay, fine.
Hello, this is Dr.
down
Go from
now.
the Seoul University. I have a question to Dr. Byrne. If we have short segment of the flow limiting dissection and the other parts are very good, do you want to prefer to implant the stent to short segment or to cover all the way to the from proximal to distal, or you want to use the short stent and the other part should be covered with the DCB?
Yeah, great question. I would say if it's a focal dissection in a long lesion, like you've laid out, I would just do a spot stent and only stent the segment that really needs it and treat the rest with a non-stent solution. Now, that being said, if it's a subintimal case, what I've seen is if you use spot stents, you get a link sausage-like effect where you get restenosis in between the stents sometimes. And so, but I've only really experienced that in subintimal cases, not so much luminal cases. So In this case, if it's a single focal dissection, I wouldn't worry about that so much and just do a spot stent. All right, let's do an angiogram and see how it looks. Let me know when you're
DMAC?
ready. Go ahead.
Wow.
Now, there is some plaque dissection. It's not flow limiting, but especially at the proximal cap, where you had that subtotal high-grade 99er. Well, so
Can you do an oblique projection to see how big is the flap?
sure. Good
Because in my opinion,
suggestion.
now the option is you can do a prolonged inflation with the DCB, and then eventually we can move for a spot stenting in that area.
Ready? There's a lot of
No.
overlap. Sorry about that. May be difficult to unravel that. Let's see. I can go more. How do you raise the II on this machine? Good. Try a little more. Let's see if we can eliminate the overlap. Ready? No, it's not easy to get a good view there. Okay, we're at pretty extreme angle. I'll try AP is the best I can do for you. We'll try one more view. It looks similar.
Yeah,
And actually, the more distal dissection looks a little more substantial.
it's not a flow limiting, but
No.
I think maybe a prolonged inflation can.
The proximal, though, I'm concerned it's also recoiling concentric. It was a bulky lesion.
Right.
Yes, it is.
You know, honestly, I'm thinking maybe stent the upper half and DCB the lower half.
That was what I think.
That's what we're thinking.
That is
So
another option.
so why don't we do this? Let's go back to our better working view,
Okay.
get a good road map, and then do you have a 5 by 80 DCB?
580 루터닉스 좀 찾아주세요.
Or you have 100? What's
yeah,
your longest? Just get your longest, whatever
Longest
it is.
one is 120, right?
You might as well use 120. Ready?
아니, 루터닉스. 500. 500 is the longest. 5 and 100. Lutonix.
Yeah, let's use that.
Okay. 500
5,
주세요.
100. All right, let's road map that. Freeze stuff and
So you, Bob, you're going to do the DCB distally,
Yeah.
and then you're going to stent that more proximal
Yeah. yeah, that looks highly recoiling.
I
I don't
agree.
think it'll do well with the balloon.
Dr. Bersin,
Yes.
do you use IVUS for that kind of dissection case for the SFA recanalizations?
Yes, I use it like was shown in the lectures yesterday, where you know your subintimal and you're trying to find the path. That's one good use. Another is complex lesions, where you're trying to get a better estimate of vessel diameter. To assess dissections, I don't think I need it for this upper one, because honestly, that's deep plaque fracturing in the medial adventitial layers where the lumen is actually preserved. It's just a high-grade lesion.
Just go in.
I think a stent is needed up there. Oh, okay, good. Go ahead. The good news is we got through in the true lumen all the way down. A little further. Keep going. You see right about a little more. Right there.
Right there.
Perfect.
자, 갑시다.
Okay, go up slow, gradual. 2. Reset timer. Well, it looks like we'll have a few more
I'd like to
minutes
ask
to
to
discuss.
Dr. Ida. Yeah.
How are we doing on time?
Yeah, good.
This SFA is almost 20 centimeter, and after 5 millimeter balloon, there are some dissection, especially proximal is
Let's go off overlay.
maybe not flow limiting, but I think it is quite severe. And do you prefer drug balloon or drug stent?
So I prefer the stent. So I think the DCB strategies are very ideal. But long CTO is a high risk for the re-occlusion as well as requiring the spot stenting. And from the CT angiogram, vessel diameter larger than 6 millimeter, maybe we can use the 7 millimeter stent. 7 millimeter stent is good enough for good patency. So that's why I prefer the
So we
stent
need a
implantation.
6 by long stem.
Okay.
About 100.
How about Dr. Inoue's opinion?
Do you want to use the DS?
I agree with Dr. Ida.
think we
So
should.
practically in this situation and even using drug coating balloon, the reocclusion response rate is very high. So I want to put the primary stenting.
6에 100짜리 정도.
How about Jojo?
안 돼요. Okay.
I think we have to consider the patient age. So she's already 83 years old. So she has a very high breathing risk. So the DOP duration should be as short as possible. So that's why a very long drug-eluting stent deployment is.
Maybe more.
I don't think that's the best way for me.
So you want to
Okay.
use 6, right?
Dr. Choi, Japanese rule
You can open.
DCB or stent. So
ahead,
when we apply the DCB, we can't use a stent. That's absolute rule.
Yeah.
So we have in a proximal, we have to end up with the DCB. That's our Japanese rule.
I see.
Well, we're at about 2.5 minutes here with a 5 millimeter by 100 Lutonix. We're going to go at least 3 minutes. I think longer is better.
Bob, this is 100, correct, balloon?
It is.
Did you think you went far enough distal on that lesion? Are you all the way down to where it reconstituted, or are you kind of in the middle here?
No, I think we're beyond, pretty sure. We can take a little picture here. We haven't really moved the II, so I think we're okay. Go ahead and just inject. No. Keep it up. And just inject some dye. Yeah, you can see the dye reconstituting below.
Yeah,
It's we're beyond. We're about maybe 1 centimeter beyond.
fair enough.
We had a roadmap overlay. I don't know if you saw that.
Do you usually select the diameter of the DCB by visual estimation or other method?
Well, this was clearly visual. I'm not a big fan of the quantitative QCA vessel diameters using the software that at least I have been used to because I don't find it that accurate. IVUS guided is clearly the best, I think, if you're going to go on a quantitative route. But the QCA is often off, in my opinion, by at least half millimeter, maybe a millimeter. So in this case, it looks as though the 5 millimeter is a good diameter. I think 6 would result in perhaps a higher risk of further dissection, which I do not want to do. So here we're at coming up on 5 minutes, and I'm just going to take it down then. Just got a few more seconds here, and we'll see how it looks. Okay, you can come down. That was at 10 atmospheres. So I'm going to leave the balloon where it is, just so we can have a marker as to where we started and finished. All right, let's see, we're about down. All right, ready to take a picture? So we'll have some balloon shadowing. That's the downside, but the upside is at least we have some marking of where we've been. Oh, that looks pretty good. I'm okay with that on the distal end. What do you think, Dr. Choi?
Quite good. Yeah.
You like it? Okay, so let's do this now. We're going to move the tube, but not the balloon. Okay, let's do one more roadmap for our stent on the upper end. Ready?
Ready?
Go ahead. All right, let's overlay that image.
Okay. Roadmap.
Great. Okay, we're going to exchange this out. So our plan, as we laid it out, was DCB distal and DES proximal. What we have prepared is a 6 millimeter by 100 Illuvia for the proximal.
Dr. Bersin?
Yes.
This day we have an issue about the drug toxicity and safety issues, and I saw that you decide the low tonics for the low dose paclitaxel device.
Yes.
Is your intentions?
Yes, we use Lutonics distally, and then because this requires a stent proximally, we're using an Illuvia stent. You could also use the Silver PTX. The Illuvia has been demonstrated to have a very good patency. The dosing is not higher, if anything, the same or
I
lower.
saw some FDA warning comments on the drug coding system, and did this warning system change your practice or still the same?
Yes, it did. It used to be that it was automatic to get a DCB in almost every circumstance, but not now. This, I think, is a commanding circumstance because it has a high recurrence risk. There's a high recurrence risk lesion. So I think the risk-benefit ratio is in the favor of using it. On the other hand, if you had a focal de novo lesion, non-CTO, no.
Okay, Bob. Next room are ready for the stenting, so we will come back again. It's okay?
Yeah.
Okay, thank you.
Yes, I think it's okay. So,
Dr. Go?
Hello. Can you hear me?
Yes. Please explain your case and your team.
Okay. Good afternoon, ladies and gentlemen, honored moderators and panelists. It's my great pleasure to present our live cases here in the Asan Hospital. So let me introduce our team. On the right side, the co-operator is Dr. Chang Lee, and we have excellent staffs from Asan Hospital. So, Dr. Lee, would you introduce our case?
Yes. A 62-year-old man was referred to the outpatient clinic for claudication. His ABI value was not detectable in left side, and right side is 0.22. CT angiography showed severe peripheral disease both sides. Next. You can see the CT now. CT, please. Extremity CT. And rotation 좀.
MPI 이미지.
Yeah.
MIP 이미지 있나요?
You can see the very severe calcification and obstruction in both iliac to the popliteal artery, but okay. We can check the peripheral angiography previously. Angiography, please.
So CT scan shows severe calcification of aorta and proximal iliac arteries, and also right common femoral artery is heavily calcified. So on this view, we cannot judge which site is occluded. So fortunately, here the steps have taken angiogram several days ago, and this is the baseline angio. Okay, so Dr. Lee, would you explain?
Yes, the left iliac artery, common iliac artery is total occluded like this, and another obstruction showed in the bifurcation right side iliac artery. So,
yeah, so I don't know whether you can see clearly here. So there is a short segment total occlusion on the left side at the ostium of the common iliac artery. And there is actually a big chunk of calcium. And on the right side, the proximal segment of the external iliac artery is significantly narrowed. So, and do we have more pictures downwards? The femoral arteries, maybe next image. And on the right side, the femoral artery also diseased, but the left side, the femoral artery is preserved from the disease. So this is the right side. There is again stenosis in the mid portion of SFA.
Okay.
And next, the right side, the left side, please. Next. Okay. So we can, because of total occlusion, maybe we cannot see that clearly, but there is actually no significant stenosis on the left side. Yeah. So since the ABI on the left side is lower, and also this patient felt more pain on the left side. So our primary target is the left common iliac artery at the level of the ostium, and also the stenosis on the right side, on at the proximal external iliac artery is also our target.
Okay.
So the problem is, yeah. Can you see the angiogram taken today? So, yeah, this is the baseline angio of today. Okay, so how we approach this lesion, target lesions, that's the question. So we thought, since the occlusive segment is very short, so maybe we can try by retrograde approach. And also, since there is no proximal stump at the left common iliac artery, so it is difficult to come from the other side. So if we fail with the retrograde approach, then we have to come from above. So from the radial or from brachial. So I thought, since we can go through maybe we can treat the stenosis on the right side first, and then we place a catheter at the level of aorta bifurcation, and then we use that as imaging guidance, and then we can try from retrograde to recanalize the occluded segment. So what do you think about our strategy?
Yeah, I agree. And heavy calcification, you can navigate also calcification.
Yeah. So I will show you the plane image.
So Dr. Choi.
I
So
think
this
that's
is
going to
the
be one of
plane
the
image.
challenges is the calcium.
So Dr. Choi. So I think the additional discussion point is which type of stent, cell expanding stent or balloon expandable stent, or covered stent for the calcified left CA occlusion.
Dr. Go.
Yeah. Maybe Dr. Ida knows the answer.
Great to see you. So it's very hard case.
Yes.
But I think basically from the brachial approach, from the anterior fashion, is very helpful. And also from the classification, the good landmark to go the right way. If you fail the antegrade approach, you intentionally do the subintimal approach using the out-of-band catheter and the re-entry at the distal terminal aorta.
So with this much calcium, I think it will be very difficult.
Yeah.
But we can, as Dr. Choi suggested, so we can also use the calcium as a marker. So we can try stay just in the middle, and maybe we can go through the wire with the wire. So when I come back to your question, so this is a heavily calcified lesion, and maybe there is increased risk of rupture. And also, this is we have to place the stent at the level of the bifurcation. So we need to have a good position of the device. So in the sense, maybe covered stent is a better choice.
Dr. Garcia, what do you think about the stent choice?
Well, I think that this is a really challenging case, and I think you chose wisely in how you're approaching it. The only thing I would say is that I would use a covered stent. I would make it balloon expandable. I think that you'd have to recreate, because if you look at the calcium that's there, there seems to be a protection calcium. There's this nodule of calcium right at the origin of that iliac, which means I think you have to extend into the aorta, which to me would suggest you'd have to do a kissing stent on the other side. I think that would be the easiest and probably most straightforward a way to protect both the aorta and bilateral iliacs. And then you can always stent the external. But using the co-best approach, I think that's probably the best choice, is a covered stent, balloon expandable.
So you think about kissing stents here?
I'm just concerned about there's, right at the start of where, just below that left lumbar, there's this really marked amount of calcium in the aorta proper that I think if you just stent the origin, I'm not sure how that's going to either protect or impede the flow of blood into that iliac you just stented. So I just don't know how it's going to play out, but you can always pre-dilate it and see how it looks. But that's my concern, is the anatomy here.
So to save time, so I will show you what we did. So we first dilated the right external iliac artery stenosis with 7x40 milliliter balloon. And this is the result. And then we placed the omnicaster in the aorta. And we used this caster as imaging guidance, and we gave some injections. And as you can see here, the segment, the total occlusion segment is very short. Okay, so on the left side, I inserted a 5 French Judkin right caster, and then I used Halbert O14 wire to penetrate the occluded segment. And actually, I tried several times, and one of the attempts was actually successful, but I did not know whether the wire is in the aorta or not. So because of the hard resistance in the calcified lesion, I have no idea whether the wire tip is located in the wall, within the wall, or in the lumen. So I pulled back, and then I tried again, and finally it looks like the wire is now within the lumen, and we at the time I used Astato.
Yes,
Astato 20 gram for the penetration, and then I inserted microcaster, and then I injected some contrast dye to test the location of the microcaster. And as you can see, the microcaster is now within the aorta in the lumen. So now we pre-dilated the region with 4x40 balloon. Next.
이게 마지막이었습니다. 네. 이게 마지막이고 balloon 한 개 다른 데 있습니다.
Okay, so we will make an image again here.
제가 쓰고 있습니다. 제가.
Okay. So we pre-dilated the lesion with 4x40, and then subsequently we used 7x40 millimeter balloon for the further dilation, and also to estimate the proper size of stent. So can you have the image of balloon? It's not available. So, and to our judgment, maybe 8 millimeter stent. Yes, this is the 7 millimeter balloon, and maybe 8 millimeter stent is appropriate in this case. And we also measured previously on the CT image the diameter of the occluded segment, and it was also about 8 or 9 millimeter.
Right. Yes.
So I think it's safe to go for 8 millimeter stent. So we'll use covered stent, live stent from Bob. The question is how we place the stent in this case. So as Dr. Garcia already mentioned, so the stent should protrude a little bit into the aorta to protect the calcified plaques. So then, so it'll be look a bit awkward, but then we have to think about whether we need to have a kissing stent. So anyway, we'll insert a stent first, and then we'll see the result. And on the right side, common iliac artery has enough lumen. So if kissing stent is required, then we can still deliver another stent to the right common iliac artery. Okay, so test, please. So how about this level? Do we make a picture here? 그 시냅 저기 DC 하지 말고 서치지 말고. 네. 플레인 이미지로.
네.
네.
네, 위에 거.
Ready?
네, 잠시만요. 네, 위에 거 누르시면.
Yeah. So, what do you think? It's too high, too low? It's okay. I'm doing one-man show.
It's okay. It's okay.
It's okay?
Yeah. Good push.
Yeah?
Yeah.
Okay. Anybody against it? Nobody? Okay. So.
Only me.
Yeah? Yes.
It may block the internal iliac artery, maybe left side. So
yes, that's
I think,
true. Actually,
it's time to choose one more graft stent for the right common iliac artery with a little bit proximally. You can make a new carina. So then you can save both right common iliac artery osteum and left internal iliac artery osteum.
That's a good idea. So actually, this is the shortest cover stent. So 38 millimeter.
37.
So actually, we wanted to check the position of the right internal iliac artery, but now with this position, the left internal iliac artery will be covered. So you think we may better move a little bit upward and to save the left internal iliac artery, right?
Or change it to bare metal.
Bare metal?
Without graft.
Yeah. I think if
just my opinion.
Yeah.
Yeah. So I think we can go a little bit upward.
If this is an 8 by 38, or is this a 7 by 38? What's the diameter of this?
8 by 38.
Yeah. If there's any chance you may go a little bit bigger, then it may foreshorten a little bit, and it's probably going to uncover that iliac. But
maybe we
right
need
now,
to
you may have
move
to
a
go
little bit, 2 or 3 millimeter upward.
Yeah.
좀 쇼트닝 돼서 조금만 올리시면. 어쩔 수가 없죠. 네.
테스트.
테스트 하겠습니다. 테스트.
어쩔 수가 없는 게 열타가 여기에요.
Yeah.
너무 많이
Okay.
너무
Maybe here. Yeah, I think it is safe. Okay. So one more picture.
Yeah.
Okay. So I think it's now safe.
Yes.
Yeah. Okay. Here we go. balloon.
천천히.
노미너.
네, 천천히.
8.
네. 잡았고.
5.
6.
I think if you worry about the internal iliac artery occlusion, you should put the bare metal stent at the right side,
Depression.
not the stent graft. I think it. You don't worry about the bilateral occlusion of it.
아파하십니다.
Well, I mean, to your point, though, I mean, if you really play the data game with COBEST would tell you, notwithstanding the complexity of the left, but the right side being relatively focal, you probably do just as well with just a bare metal stent. So I agree with you. I don't have a problem with that.
Depression. The patient feels a little bit pain here. Okay.
Yeah, the top of there was right where that nodule of calcium was inside the aorta.
Yes.
알겠습니다. 잠시만요. 빼겠습니다. 오케이. 놓고 일단 내려놓겠습니다.
잠깐. Subsection?
네.
Okay.
네.
Yeah. So we have flow in the left internal artery. So now I think we need, so in this case, a kissing stent. What do you think?
Yeah.
Okay. Balloon expandable or self-expandable stent?
What do you think, Fabrizio? Balloon or self?
Generally, I prefer to use the same as on the contralateral side to avoid
Yeah, but
any
then
clashes.
we have to cover the
to use
right
another balloon.
internal artery. So I think it's better to use non-covered stent. So 8 by, maybe this one is 30, maybe 50 something.
60 있을 것 같습니다.
60?
네, 아래쪽까지 보셔도 돼요.
Dr. Ko, are you going to then put that
balloon expandable,
that new balloon expandable on the right at the same level as the left?
Yes.
You'll recreate the carina. I think that's optimal.
Yeah,
58.
I agree. Dr. Go,
Yes.
we have time limit and we're gonna move the next room, and I think you should finish it and summarize your procedure.
뭐야? 라이프 스트림이야? 라이프 스트림이야?
Yeah. So
are you going to come back or we have to close?
I'm not
our
sure.
live case?
We have only 7 minutes.
Okay, so anyway, the most important part is done.
Yes.
So, okay, we'll implant a bare metal balloon expandable stent on the right side, and then we'll do kissing balloon, and then we'll check the flow, and I think that's then most of our work is done with that.
Okay, thank you very much.
Okay, thank you. Bye.
Bye.
Bob, Dr. Lee.
Okay, so I think
Okay.
you left us at the point where we were deploying the Alluvia stent. If you look at the fluoro image, it's just the deployment there, and then go to the next. Then we high pressure post dilated with a 5 millimeter at 18 atmospheres. Okay, go to the next and next. And here's our result. Looks excellent.
Excellent result. Yeah.
Now go to the next. Here's the lower runoff to balloon result. You can see there's 2 intimal tears, but we were of the opinion they're non-flow limiting. So our feeling was to leave that alone.
Excellent.
We wanted to.
Did you overlap the DCB and the DS?
Yes, we did.
I think that is very important.
Yeah. I
drug
don't know the
delivery.
data on that, but I think the results from a CTO to this is remarkably good. And clearly she'll have benefit. The question will be the durability of it. And how do you surveil your patients for follow-up at this point?
I think there's a variability between the operators. For me, I do ABA after the operation, 1 month after the operation, but thereafter, if I usually feel their pulses and their symptoms and do not do any other tests.
So in my practice, everyone gets a 1 month. For the really high-risk recurrence cases, I'll do a 3 month, and then 6 and 12. If it's a low risk of recurrence, I skip the 3 month. I think with that, we have, I think, a very pleasing result. I'm quite happy with that outcome. I think we'll conclude at that point, and thank you very much.
Thank you very much. Excellent job.
Very good job.
옆방으로 옮겨주세요. 옆방 좀 보여주세요.
Thank you.
Dr. Go will be back. Will.
Oh,
Yeah.
you're back. So
Yeah. Finish? No?
almost. 상태가 잘 안 보이는데 좀 magnification 할 수 있나요?
Dr. Go, I can ask one question. You're doing the kissing stent with the one side is bare metal and the other side is the covered stent.
Yes.
Did you have any experience of the long-term follow-up for that case?
No. So we follow this patient. Okay. So I think the proximal part is about the same level. So we can go with the stenting. So balloon. Nominal?
노미널 뭐예요?
Nominal 8.
8. Okay, 천천히. So slowly.
Okay.
So we also measured the size of the iliac artery on the right side, and it was also about 8 millimeter. So
뭐지?
아프시면 얘기하세요. 네.
Eight.
8.
Eight.
Okay. Deflection.
Would you do the
So-
simultaneous
Yes.
Kissing.
ballooning with a smaller size?
팔짜리 벌른 하나 주세요. 8에 40.
이쪽을 빼시고 이쪽 건 하실 거죠?
네. So we need 8 by 40 balloon.
Dr. Ko, do you normally go to the nominal of the artery, the reference, with your stent, or do you try to go 1 millimeter smaller and then build up to it for these iliacs? Because I've generally just been a little frightened about going to the.
Yes, I'm very cautious about doing.
I worry about the rupture.
Yeah, angioplasty in iliac, especially in external iliac arteries, is vulnerable to rupture. So I just look at the size of balloon and I ask patients to say if he feels pain, and as soon as the patient feels pain, then I stop. Okay, and I apply only low pressure, and then I'll be very cautious. Here we go balloon.
Nominal 6.
4.
4. 아직 4 아닙니다. 4.
Okay, that's enough, I think. Okay. Maybe I think this is enough. Okay. So now kissing
여기야?
here.
좋았습니다.
So I think it's better, it's safer to place balloon a bit upward. So how about this? Okay, balloon,
네.
nominal pressure.
노미널.
Nominal 6.
내 거는 8. 6.
Okay, stop.
Yeah.
Okay, the patient does not feel pain. Okay, so deflection.
2, 3.
So we need
Diagnostic.
yeah, omnicaster.
Yes.
Okay. So we remove the balloons.
이쪽도 빼고 이쪽.
네, 빼죠. 너무 무리할 필요 없을 것 같아요.
네.
Yeah, pressure is okay and patient complain no pain, so I think it's okay.
이쪽으로 옵니다.
네.
Dr. Go, during procedure, you usually check the continuously monitoring the blood pressure.
Yeah, especially for the iliac interventions, yes, and sometimes also bilateral pressure monitoring. It's very helpful to see whether there is any significant pressure gradient over the lesion. 이쪽도 볼륨 뺄까요?
네, 볼륨 빼겠습니다.
와요.
Maybe this is the last shot.
Yes.
The omnicaster does not form here. So okay. So subsection please.
줌아웃 하겠습니다. 줌아웃,
오케이.
줌아웃.
오케이. 갈게요. Yeah, it was a hand shot, and Dr. Lee feel a little bit weak today. He does not have the lunch. So we try again one more time. So a younger doctor will try again. So maybe we place a little bit frontly. Okay.
잘 들어.
Yeah.
Okay.
So
Great.
it's a little bit difficult to see, but I think there is no rupture, and the pressure gradients. I think there's no pressure gradient. So what do you think?
Very good. Patent bilateral ileal artery, internal ileal artery, and no leakage. Very exact kissing, and I think everything is okay, perfect result.
Thank you. Thank you.
Very good. Very good.
Yeah.
Thank you very much.
Okay. Thank you very much. Bye.